What I should say, doctor doesn't need any introduction. We all know him. He's known as the father of diabetology and endocrinology. It's a huge pleasure for Howrah Diabetes Study Society to welcome Professor Dr. Shamur Banerjee for the next session, and he will speak about improving kidney disease and cardiovascular outcome with Finridone, trials to clinical. And to chair this particular session, I would like to invite Dr. Jyotidev Mukherjee, Senior Consultant of General Medicine, and Dr. Kaushik Shah, HOD Medicine, KPC Hospital. I welcome speakers, sir, and chairpersons on the dais. Thank you.
Good morning, everyone. This session is specially for the new molecule that is called Finridone. I think we are getting these molecules for the last 1 year, and more than 1 year probably. And we have got the experiences of starting this Finridone in our clinical practice. And for this, I think today the topic is improving the kidney function and the cardiovascular outcome with Finridone from the trial to the clinical aspects. I think Dr. Professor Shamur Banerjee is my teacher also. I think Sir has got no introductions for the speaker. I think the stage is yours, sir.
Slide changer ekhane de beriye geche amle sir ektate light beriye geche changer with laser. Thank you. Am I audible? I am very glad to be present in this program of Howrah Town Diabetic Society. To my knowledge, there are now people from all over the India. I don't know whether any district has been able to form any society for diabetes or not. Credit goes to Mridul, Guru, Sanjay Sir, and so many people. And last time I was offered the honor of giving the oration, very difficult job. I could not take any slide from any company. I could not take any material from any book or journal. The topic was journey of a book writer. And they gave me the privilege. I am going to discuss today some point which is concerned with the what is next slide? The last slide asche. No, the last slide. Two box তিনটে খুলেছে মোটে এই তো এখানে আছে 2 নম্বরটা খুলো পরটা আসবে তো I am going briefly to my topic. Sorry. কোথায় যাও এটা আসবে next. I'll discuss about the CKD in type 2 diabetes as a high disease burden in India. I think you know all that the term diabetic nephropathy has been changed and now we call it as diabetic kidney disease. I am not going to details why it has been changed, but we will have to accept. And the fact is, this is 2021 data, 77 million are suffering from diabetes, and out of the diabetic population, 35 million have got CKD and mostly are undetected. I can ask you, ask yourself, how many patients at the beginning you go for renal screening, one eGFR and albuminuria, and how many patients if normal you do it annually, which is highly required. And for that reason, the data is very low for us. And people with CKD and type 2 diabetes are at an increased risk of death from cardiovascular related cause. Our question is why? Same pathology, vascular etiology, inflammation, oxidative stress and others. They are all related to the same disease, and the same person will have kidney disease, heart disease, brain disease, sarcopenia, dementia, etc., etc. And data has shown if the patient has no CKD or type 2, incidence of the cardiovascular disease is 3.4%. When they have got both, it goes to 19.6%. This is the data when we patient have got. And with merging of the time, the incidence rate also increases. And these diagnoses should be done from the GFR and albuminuria, not a single one. I will show data. If we only depend upon albuminuria, it may give a false picture. So how to classify the albuminuria? A1 less than 30, A2 less than 30 to 300, A3 more than 300. One rider is, before doing albuminuria test or albumin creatinine ratio, we don't do now 24-hour albuminuria, spot urine, you must check the routine urine. If there are pus cells, if there are casts, they will increase the albuminuria. I will diagnose it as a diabetic nephropathy. And if routine urine shows gross proteinuria, that is non-diabetic kidney disease. In diabetes, 20 to 25% chance of having non-diabetic kidney disease. If diabetic may have SLE, diabetic may have so-called immunological nephritis, etc. Do one urine routine, then ACR test, not directly. These are the 3 stages. For the GFR, more than 90, it is very easy. From age and creatinine, you can do from the formula, it is in the net. More than 90 is normal. G2, 60 to 89, G3A, 45 to 89, and G3B, 30 to 44, G4, 15 to 29, below 15 is end stage renal disease. Medicine are gradually approaching, and other than insulin, there are many medicines which you can use even into the end stage renal diabetic stage, and you will have to do both for assessing whether the patient is having any sort of proteinuria or not. Renal biopsy, very rarely done. Only when we cannot diagnose whether it is a NDKD, non-diabetic kidney disease, or it is a DKD. 10-year standardized cardiovascular mortality by diabetes and kidney disease studies, I have just shown that 19.6%. If a patient has got both kidney disease and diabetes, the risk of cardiovascular diseases are 19.6%. Sorry. Risk increases of cardiovascular events by 10-fold in patients with stage 1 or stage 2 CKD compared with patients without CKD. When you go for the other stages, the risk of cardiovascular diseases are more and more. Albuminuria is predictive of kidney and cardiovascular disease. The more the albuminuria, starting from 1.5 gram per day to 3, there are more chances of cardiovascular disease and more chances of the renal deterioration also. So albuminuria is a marker for vascular disease. It is not only indicates kidney disease. Albuminuria means cerebral stroke, albuminuria means coronary artery disease, albuminuria means other problem also. Guideline, ADA, KDIGO, ESC and ESD recommend screening for kidney dysfunction by laboratory evaluation of both, and this should be done twice annually, and if ACR is more than 300 or GFR is below 60, then you will have to repeat every 3 months or 6 months according to the need. And on one test, you cannot declare patient has got albuminuria. If not, it is very high. So you will have to repeat the test. But you cannot depend only on albuminuria. This patient who are showing albuminuria in the stage of 610 and appears to be of low risk, when you apply the GFR, the patient shows more higher risk. So you do the both. Reducing albuminuria may reduce cardiovascular and kidney risk in patients with type 2. This is proved beyond doubt. This group, 50% reduction by reducing 50% of the albuminuria and cardiovascular disease. CKD and DBD in type 2 diabetes is driven by the combined effects of metabolic, hemodynamic and inflammation. Metabolic, I am coming to later on. Hemodynamic, how to control. Inflammation and fibrosis, this is mainly controlled by the MARSA, mineralocorticoid receptor activity, non-steroidal. The new drug is finerenone, encacerone and others are waiting. We have got the molecule finerenone. SGLT inhibitor have got some anti-inflammatory effects. Pioglitazone has got some anti-inflammatory, prevents the TGF beta 2, preventing the nephrosclerosis. These are the other molecules. And what happens finally? Tubulointestinal damage, glomerulosclerosis, mesangial expansion, glomerular hypertrophy, and similarly in the heart, these type of changes are very common. Despite RAS blockage, SGLT inhibitor inhibition, patient may progress to diabetic kidney disease advanced stage, so we will have to think of other treatment facility. And what they are? Hemodynamic control by ACE inhibitors, ARBs, thiazide diuretics, dihydropyridine, calcium channel blocker, SGLT inhibitor, metabolic by the antidiabetic, but inflammation can only, and fibrosis, majority cases can be controlled by the so-called mineraloreceptor activator inhibitors. And how they act? Finerenone, hyperglycemia, high salt levels, oxidative stress, they all lead to MR activation and lead to fibrosis, cardiorenal disease. And finerenone, by acting to different cofactor and DNA demodulation, they lead to inhibition of this inflammation and other resultant fibrosis, etc. The 4 pillars of treatment of diabetic nephropathy are: number 1, RAS blocker. I am not going to details, you know. SGLT inhibitor, you are tired of listening to SGLT inhibitor. Finerenone is the new drug, decrease inflammation, decrease fibrosis, decrease endothelial dysfunction, decreases tissue remodeling, decreases proteinuria. And next is the GLP-1 receptor analogs. But the unfortunate thing is most of the GLP-1 analogs are injectable, only one available oral agent is very costly. Finerenone, a selective non-steroidal MRA, blocks MR overactivation which slows kidney and cardiovascular disease progression in patients with type 2. And they ultimately act on the inflammation and fibrosis, to some extent on the hemodynamic factors, metabolic factors, and protects both heart and the kidney. You can raise the question, how does it differ from so-called spironolactone, the available and the cheaper one? These are the comparison of the spironolactone, eplerenone and finerenone. These are mostly potent against mineralocorticoid receptor activation, and selectivity of the receptor is highest. Highest selectivity for MR receptor means lower side effects like the gynecomastia, testicular suppression, etc., etc. And half-life is low, but ultimate duration of action is more. Only less advantage is effect on blood pressure is less. So finally, they differentiated the effect on markers of the inflammation and fibrosis and short half-life, but action available is more prolonged. So finally, they lead to the heart and kidney protection. And what I get out of that, Figaro and Fidelio, there are many studies and they show definite sufficient number of patients to allow robust investigation of the effects of finerenone on kidney and outcome, and they will show definite improvement with finerenone in cases of diabetic kidney disease. The Fidelio and Figaro trials, Fidelio DKD, clinical efficacy primary endpoint, it is here, that is time to kidney failure, sustain more than 40% of the eGFR decline or kidney related death. Key secondary endpoint, same as primary endpoint of Figaro DKD. And they are time to cardiovascular death, non-fatal MI, non-fatal stroke or hospitalization for heart failure. And they show also in the fidelity study much improvement in the study. I am going to the Figaro DKD key outcome. When you consider as the endpoint as hospitalization for heart failure, 13% reduction for the hospitalization for heart failure in patients of DKD. When we think of the lowering of the end-stage renal disease, there is 36% lowering of the end-stage renal disease compared to placebo, then finerenone, and there is also lowering of the heart failure by 32%. These are new onset heart failure in cases of diabetic kidney disease. In the Fidelio DKD study, when endpoint is also lowering the end-stage renal disease, there is lowering of the 18% chance of developing diabetic kidney disease who have no kidney disease at the trial starting, and also there is diminution 14% of hospitalization for heart failure. There is diminution of prevention of EGFR up to 57% and the incidence rate is 27% lower. So, renal decline is minimized and the acute effect of finerenone is a drop in EGFR, but the long term effect is slowing of EGFR. You know also with RAS blocker there is initial suppression of the GFR, it is lowered, but ultimately it improves. So, finally, it is nephroprotective, not nephrotoxic. A baseline patients had well controlled BPA1C 46% with cardiovascular disease of cardiovascular medication. I am not going to details. In fidelity, where the endpoint was that lowering the risk of GFR by 57%, there is improvement seen with 23% cases. This is a curve and this is not negligible. There is also 14% chance of lowering the mortality and morbidity from cardiovascular disease. There is also 22% reduced risk of first origin of the heart failure and also 70% lowered risk of cardiovascular death and first hospitalization for heart failure. Finerenone demonstrated significant on-treatment reduction in the incidence of all-cause cardiovascular mortality, which is available with SGLT inhibitor, DAPA and MPA, not with CANA, and they improve also the all-cause mortality, but cardiovascular mortality, sudden cardiac death, they lower, but this is not statistically significant. There is lowering of the 32% ACR from the baseline by 4 months, and in the fidelity, those patients who are on SGLT inhibitor, 32% reduction in the lowering of the UACR. When we add finerenone, there is further more 5%, that is the lowering goes to the 37%. This shows if the patient even is on SGLT inhibitor, you add finerenone, you will get extra advantage. In fidelity, whether the patient was having SGLT inhibitor and you have added the finerenone, they shows advantage, extra advantage of finerenone for renal protection. Similar adverse effects compared with placebo and increased incidence of hyperkalemia. And I am coming how to monitor the potassium level. Demonstrated consistent heart and kidney benefit across various subpopulations. Those patients who are all SGLT inhibitor or GLP-1 receptor analogs use, finerenone is again useful as an additive drug. A patient whether has got atherosclerotic cardiovascular disease, in already setting cardiovascular disease, they will prevent coronary artery disease, death due to heart disease or heart failure, and those who have no heart disease apparently, they will prevent. Regardless of the baseline A1C, insulin use or diabetes duration, they are active across different stages. They are active irrespective of age, sex or obesity and regardless of blood pressure. So, nothing to be considered whether I should give this molecule except the potassium level. Recommendation for the management of CKD in type 2 diabetes includes, there are now 3 distinctly different changes of drugs, RAS inhibitor, this finerenone and SGLT inhibitor. These are the drugs recommended by KDIGO, ADA and also ADA KDIGO combined recommendation. Finerenone is recommended in heart and kidney guideline for patients with CKD and type 2. In patients with CKD and albuminuria who are at increased risk for cardiovascular events or CKD progression, a non-steroidal MRA is shown to be effective in clinical trials to reduce kidney disease, to reduce cardiovascular disease. For patients with type 2 and CKD, they are also equally effective. KDI recommendation is also more or less same. They have added that you can use up to GFR 0.25 and normal potassium level. About the new ESC guideline, European Society of the Cardiology, this you can add where statin is already on to lower cardiovascular risk. You can add to ACI or ARB patient already receiving to reduce kidney failure. You can, finerenone can also be used when patient is receiving SGLT inhibitor and to when the patient is under BP control drug even, it reduces cardiovascular and kidney failure risk. In patients with CKD and type 2 diabetes, finerenone. What is about the ESC heart failure guideline, finerenone in patients with CKD and type 2 diabetes recommended to change the risk of hospitalization for heart failure, and also you can use in cases of SGL2 inhibitor already receiving. What is the dose? For all patients to start, do one serum potassium. It should be below 5. Someone recommend it should be below 5.5. Normally it's up to 5.5. Start with 10 milligram. If GFR is below 60, if GFR is above 60, you can start with 20. Better to start with 10 milligram. Monitor every 4 months. Adjust dose according to the response. If potassium goes higher, 5.5, temporarily stop and continue the medicine. Contraindication and precaution for the use, finerenone should not be initiated in patients with severe hepatic impairment, of course hyperkalemia, in cases of Addison's disease, and concomitant drugs like itraconazole, clarithromycin, ketoconazole, ritonavir, neflinavir, etc., which are all CYP3A4 enzyme inhibitor. Finally, in the summary, I like to place before you that in fidelity, finerenone significantly reduces the risk of cardiovascular disease, heart failure, kidney outcome with a well-tolerated safety profile in a CKD population. Timely initiation of finerenone can preserve kidney function, which is important to optimize cardiovascular management. Finerenone is guideline recommended, ADA, ESC, then KDIGO and combined ADA and KDIGO guideline to reduce kidney and cardiovascular outcome in patients with CKD and type 2. My dear friends, in 1902, we lost Swami Vivekananda. In probably 1945, we lost Rabindranath Tagore. Earlier, we lost Ishwar Chandra Vidyasagar. They are all diabetics. There are no medicine for diabetes. When I passed medicine, I am an old person, not so young like Sanjay Sir or Guru, etc. When we passed in 70s, there was only 2 drugs. One is fenformin, now obsolete, and another is Deonil, which is very, very rarely used. At that time, we could not think of lowering the blood pressure. Now in 2023, we can challenge any level of blood sugar can be controlled. Only whether you know the subject, that does not mean whether you read my books only, I am sorry. And second, whether the patient is really willing to do that. My teacher told, don't believe a diabetic and a drunkard. I was in the round with my teacher, Professor T.K. Shah, gross alcoholic cirrhosis, subject of Dr. Todi. Every day telling, no sir, I never drink alcohol, never drink alcohol. One day my sir told, you go to the cupboard, check it, what is the bottle? He told, sir, it is a carminative mixture. Sir told, bring it, open it. Full of alcohol mixed with carminative. I am not going to tell before you how our top leaders drink alcohol in the stage. I am not going to tell you, you may practice it. But in 2023, if the patient is willing and the doctor is knowing the subject, I don't believe blood sugar cannot be controlled. Now it is easy to control. Now we have started thinking whether organ complication can be prevented or delayed. That is possible with this present group of drugs. Thank you for your patient hearing. I am really grateful to you for making my 10 books successful. This is a book for this 2023. Long back I have written details about finerenone in this, and this contains all the subjects of the nephritis. Thank you for your patient hearing. I am very happy I kept 3 seconds for Sanjay sir.
Thank you, sir, for giving us an excellent lecture as always. So before going to the floor, I think I have 1 or 2 questions. As these 2 trials has been done, that means the Fidelio and Figaro, I think very less amount of the patients are recruited for the SGL2 inhibitors. So how can I say that these drugs like finerenone, because it's very costly drugs, so whenever we start in our clinical practice giving the drugs with a range of 70 to 80 rupees, so what is the exact benefits as head-to-head compared to the SGL2 inhibitors and the these non-steroidal MRA? So that is my 1 question.
I know every stage is money sensitive. When we started using newer insulin, when we started gliptin, etc., this question came. But it is also true, with our use, the prices come down. It has come down with the gliptin, it has come down with the SGL inhibitor. In the future, I hope the price of the finerenone will also come down. Second point is, when a trial is done, that had to be on limited patients number, because lakhs and crores of people cannot be included in any trial. And that is after when the patient is used, that is not randomized control study. That from our experience we get when we use, but we don't use, will not increase our experience, and our ignorance means damage to the patient, sufferings of the patient. Second point, SGLT inhibitor finerenone, I have shown by many data, where you have used SGLT inhibitor, you add on the finerenone, it will give extra advantage. Price I am not going to quote here, it is cheaper than oral semaglutide, which is also nephroprotective, and hopefully in future if we all use, price will come down. If we don't use, price will be in the same level. It is definitely improving. I am using, I have seen many doctors to start. There is a saying, we practice that thing which we learned earlier, we practice that thing rarely which we learned recently. But someone will have to come forward, use the molecule, if useful, recommend to others, if not, reject it. Finerenone will start a huge big trial including cardiovascular, other vascular disease, etc. going on, that will come. And before this, there are multiple studies known as ATS trial, etc. They have also strengthened our knowledge. Thank you.
In continuation with that price, I can highlight one thing. The price of 10 milligram and 20 milligram is almost same. So if we used to use 10 milligram tablet, we can half the dose of 20 milligram. Anyway, I have a query regarding what is the role of finerenone in non-diabetic CKD with high USCR more than 300?
Very good. Today the subject is on diabetes. I did not comment. There are trials also in non-diabetic. They are controlling, lowering the proteinuria. And I have shown whether the patient has diabetes or not, whether the patient has heart disease or not, whether the patient is elderly or not, they will have their effect on lowering the protein. Ultimately, action is on the suppression of the mineralocorticoid receptor activation, suppression of inflammation, TNF alpha, interleukin 6, etc., etc.
Now, would you consider
DNA modulation?
Would you consider finerenone in non-diabetic CKD
100%.
Within
100%.
30 to 300?
Yes, yes. In plain nephrotic syndrome also they are active.
Okay, thank
but
you,
the
sir.
focus is more on the diabetes because market is big.
Thank you, sir.
Any other question from floor?
So we get many patients who are newly diagnosed diabetes with G2A2 level. Will you start finerenone at the at that moment? G2A2. You will start 100%. It, or you will wait till the control of the blood sugar, because it said that micro diseases will be controlled with control of them.
The probable etiology of diabetic neuropathy. One is hemodynamic, another is your metabolic, another is infection. So when you are controlling the metabolic part, the fibrosis part, inflammation is going on. Of course, with lowering of the blood sugar, there will be some minimizing, but ultimately you need another. And that I have shown those patients who are also on a SGLT inhibitor. In those cases, this finerenone is helping to prevent diabetic nephropathy. So when proteinuria, GFR stand, again I repeat, you will have to do both. You cannot depend only one.
Yes,
if
G2A2.
you see that is in the level of the nephropathy, you have to start the medicine.
Right from the word go?
Yes, from the very beginning.
Thank you.
Any question?
Sir, I have another question. In cases of a patient who are in heart failure with reduced ejection fractions, that means FREF, so we have to start whether the MRA or non-steroidal MRA like finerenone, because MRA like spironolactone is the class 1 indication in this group of the patients, and whether we had to shift from the spironolactone to finerenone or we had to
with diabetic or non-diabetic?
Either the diabetic or non-diabetic in both
We
the
only
cases.
lacking with the finerenone is effect on the blood pressure. Heart failure, if compared, more or less same. But we use spironolactone with the idea of lowering blood pressure, that is very poor in cases of finerenone.
Because in heart failure with reduced ejection fractions, I think the class 1 indications is the MRA. it is not at all written that this non-steroidal MRA should be used because
No, that is a new molecule. We'll
yes,
have to gather our...
that's why I'm asking you, sir,
And
what's
the
your
money
opinion?
sensitivity, I don't care. Patients spend thousands of rupees in the restaurant for taking foods. They spend a lot for this alcohol. And when I speak of medicine, they think it costly because the mentality is not prepared to spend for the money and to pay to the doctors.
Yes, that's true.
They will pay to the massage clinic 5,000 a day, Habib's Saloon
Yes, sir.
4,000. Before this puja, there is huge queue in front of the Habib's Saloon. 4,000 for hair dressing, for liver, kidney,
Yes,
and
sir.
heart.
Sir, another...
I know why is the reason. When I purchase a fridge and the company gives warranty for 5 years, I very rapidly, very bad way use the machine because if it is gone, the machine will be repaired at its cost of the company. So who has given this machine? Almighty God. ये साला उसका जीत है, उसका करना है मेरा जो আমার শরীরটা ভগবান সালা সামলাবে আমি কেন করতে যাব আমি যা খুশি তাই করব আমি একজনকে বলেছিলাম এত অ্যালকোহল খাচ্ছেন লিভার স্যার जिंदगी जीने के लिए एंड दे नो एवरी रेट्स सर 30 लाख में लिवर लगा देता है मैं दारू नहीं पिएगा एक जिंदगी में किडनी 5 लाख में मिलता है कौन साला ये फिनेरोनन खाएगा
Sir, another issue is that regarding the hyperkalemia. I think they have said that after 1 month, we have to check the potassium levels after starting this Finridon.
After starting 1 month, then every 4 months.
Every month. Sir, what is your opinion? That means I have started around more than 100 of patients with Finridon for the last 1 year. I think not more than 5% of the patients is actually having the hyperkalemia after starting the Finridon. What is your experience?
When pioglitazone first came, it was claimed to be hepatotoxic. Routinely every month do SGOT-SGBT. Subsequently came to learn it is not hepatotoxic. Even in cases of NAS, NAS is changed. Now it is called as a metabolic associated fatty liver disease, metabolic associated liver disease. A steatotic liver disease, MASLD. टोडी साहब डेली चेंज करता है पहले था नैस इसके बाद NFLD अभी हो गया MSLD if you start pioglitazone in MSLD with high SGOT-SGBT GGT that will come down so after our experience probably that time what he is telling is correct but for rider potassium ज़्यादा हो जाता है so probably check after 1 month if the person is stable then we will shift for less but keep it in mind when the creatinine is worsening then you will have to check the serum potassium. But if you combine with SGLT2 inhibitor, chances of hypokalemia will be less.
Yes, thank you, sir, giving us the excellent atmosphere. And although it is a new drug, I think we are using for the last 1 month. I think we can have more experiences after using this Finridon in our clinical practice. I think we should aim at this right moment and give the other lectures to continue. Thank you. Thank you.
Thank you.
Thank you. Thank you so much, sir. Sir, kindly stay back for the felicitation. I request chairpersons to kindly felicitate Dr. Professor Shamur Banerjee. A small token of appreciation from Social Welfare Organization Shongbedon. Thank you so much, sir, for enlightening the whole crowd who is present here, and thank you, chairpersons, for chairing this particular session.